There was a lot of updates of data that we'd already seen. That was a kind of a big theme that came through. There was analysis that the FDA did looking across metastatic non-small cell lung cancer trials of patients who had a PD-L1 expression of 1 to 49%. And what they showed was that for that population, using this cross-trial comparison technology or technique, I should say, that the combination of chemotherapy and immune therapy seems superior to immune therapy alone for patients with that 1 to 49% expression. There's an ongoing trial trying to answer that question as well. So we'll have more data, but that was interesting to see and sort of supported what I think most of us do in practice now anyway. But otherwise, it asked a lot of updates. There were some interesting surgical updates, some radiation updates, but I was focused more on the systemic treatment choices. There were a couple of trials looking at adjuvant EGFR TKI in patients who have EGFR mutated non-small cell lung cancer. In the United States, we use the osimertinib at that setting for the most part, based on the ADAURA data, which showed a profound disease-free survival benefit. These trials, though, continue to follow this theme with EGFR TKIs in the adjuvant setting of disease-free survival benefit with gefitinib or lorlatinib, not nearly as good as what was seen with osimertinib for disease-free survival, but where we have the OS data now with some of those other trials, there was no difference, no benefit. So it's interesting. So we'll need to, I think it tells us we need to continue to follow as we understand for the early stage patients, what's the optimal strategy to help cure more patients. Of course, screening, finding it early is one of the most important steps there. And I think it's always important to talk about that. Now, when someone is found to have early stage lung cancer, we know we need biomarkers to look for EGFR, to look for PD-L1, and that can help inform treatment.